Hello and welcome back. This is Dr. Ajinkya here. So today is the fifth case of OPD case discussions, and as you can see on the screen, this patient is a young middle-aged patient, male patient, and came to the OPD with complaint of recurrent left side nasal epistaxis. And as you can see, I'm doing the anterior rhinoscopy over here. This is a thyricum speculum. This is where you hold a thyricum speculum in the left hand, and the patient's left nasal cavity is clearly seen. Now, the moment we widen up the nasal cavity, we can see a smooth surface, shiny reddish surface mass directly in the left nasal cavity. Now, most of the students will consider this as the inferior turbinate, red, boggy, inferior turbinate hypertrophy, but there's a particular method of how you can differentiate any nasal lesion with the inferior turbinate hypertrophy. So, you got to decongest the nasal cavity with adrenaline solution, and in some time, the inferior turbinate, which is hypertrophied, will come back to its normal size. And if it's a nasal mass or any vascular lesion or any polyp, mostly it will not reduce in size. So that's the basic concept of how you can differentiate that with a inferior turbinate swelling or a nasal mass. So that is one thing. And the patient only had one complaint, and that too recurrent left side nasal epistaxis. No obstruction, no facial pain, no puffiness, edema whatsoever. No difficulty in breathing as well, no snoring, no mouth breathing, because it was a very not large mass, only a mass which of size a few centimeters. So there was no prominent nasal obstruction. So we did the patient's anterior endoscopy, and as a standard protocol, we assumed immediately that this could be a nasal vascular mass, and this mass was arising from the nasal septum, and it was completely separate from the lateral wall of nose, had no contact with the inferior turbinate. And on proper endoscopy after decongestion, we could see this mass like this. So this is the nasal secretions which have undergone crusting because of excessive exposure to dry air, and this you can see the yellowish whitish crust formation because of long standard chronic case. And not that chronic though. Capillary hemangiomas are very rapidly growing masses. The patient may have secretions over it and may not even come to know about the mass. But the mass is rapidly growing, so it's very recent onset, and the patient may experience epistaxis as well. And if there is excessive air exposure, this may lead to crusting of the nasal secretions over the mass. As you can see, this patient had crusting. So this is a nasal lesion, reddish over here, pale over here, and few patchy areas of blood arising from the septum. It had a base. Now, the capillary hemangioma, which is also called as the lobular capillary hemangioma, mostly arises from the midline, that is the nasal septum, and that too in the anterior inferior half, anterior end of the nasal septum near the little's area because of the excessive blood supply over there. Very rarely it may appear in the posterior superior or the in general posterior region of the septum, or may arise from maxillary region sometimes. Very rarely, but most commonly lobular capillary hemangiomas arise in the midline, that's the septum. So this was the case. It may have two types of support. One, it could have a stalk. I think in this case it doesn't have a stalk. The other case has a broad base. So in this case the patient had a broad base for this capillary hemangioma, and we suspected immediately that this could be a definite case of capillary hemangioma. It has to be a hemangioma because of its typical size and its attachment to the septum with a broad base and recurrent epistaxis history. Now, it can also be angiofibroma, a small angiofibroma, so you have to keep that in your mind as well. But this is a straightforward case of a capillary hemangioma. So we did a CT scan done, and in the CT scan we just could see a small tiny opacity which is attached to the nasal septum, as you can see, and somewhat secretions being in contact with the inferior turbinate because of the crusting which we could see over here. This is all crusting, but had no proper physical contact with the lateral wall whatsoever. So So on the clinical, radiological, and the endoscopy basis, we concluded that this could be a case, this has to be a case of a hemangioma, and depending upon the origin, it has to be a capillary hemangioma, the midline origin, but the lobulated capillary hemangioma can be labeled only after its final histopathological examination. So we did the surgery. Well, it's a very small surgery. You just have to take a bipolar cautery, you have to take the base of the capillary mass, and you have to cauterize it, remove it. So normally it is attached to the nasal septal flap, the mucoperichondral flap. So you have to remove that nasal septal flap, the adjoining area of the base. Also you have to remove the adjoining nasal septal mucoperichondral flap, as well as the perichondrium of the nasal cartilage also you have to remove, so that the attachment is properly removed. Normally we do not remove the septal bone, the septal cartilage as such, but we remove the perichondrium of the cartilage and the nasal septal mucosal flap of the patient, which is attached to the mass over there, so that there are no chances of any recurrence. And once we do that, we have to cauterize the surrounding margins for sure. If you do not cauterize, it still may have a chance that the attachments maybe still be left behind and may lead to a future recurrence. So as you can see, I'm doing a cautery over here of the base as well as the margins of the mucoperichondrial flap of the septum. And as you can see, this is the cauterized base, so there's no chance to be taken. You have to properly cauterize the base and the area, and that's it. That's the only thing you have to do. Be sure that you do not perforate the septal cartilage, because if you accidentally perforate the cartilage, you may even injure the opposite side mucoperichondrial flap, and it may lead to a perforation. So you just have to be careful and cauterize the left side, or you can say the unilateral flap, and it will heal or mucosalize in given future time. So it does not lead to any perforation, so it's a very safe method. And or you can also use a coblation. Remember, do not use the ablation method, but use the coblation mode on that wand. So this is how you do it, and this was the mass in toto which we removed from the base. It is roughly around half a centimeter. So it is roughly around half a centimeter. So the normal size is few millimeters to few centimeters. In this case, it was roughly a half centimeter. And histopathology was typical finding. We could see, as you can see on the screen, this is a typical histopathological finding of stratified squamous lining epithelium, and with vascular proliferation, slit-like capillary spaces surrounded by spindle cell fibrous tissue. So no evidence of malignancy seen. So this is a proper, as if I just zoom this for you guys, you can see a lot of spaces, lobulated spaces of the capillary surrounded by cells having a single layer of endothelium over there. These slit-like spaces, these are the numerous capillaries which are present in a form of lobulated pattern, and hence the name is given as lobulated capillary hemangioma, mostly arising in midline. Now it can affect any age group, even children, newborn infants, young children, middle age, old age people can be affected. Male, female, both can be affected, but commonly it's seen that in cases of females it is much more common. And the age group, though it can occur at any age, most commonly is seen in the third decade of life. And this is a benign tumor. It is a rapidly growing tumor. Remember that it is never a slow growing tumor. It is a rapidly growing tumor. It grows very fast, and this is how you should remember the points for basic capillary hemangiomas. The counterpart is the cavernous hemangioma. The cavernous hemangioma is commonly seen on the lateral wall of the nose, and most commonly cavernous hemangiomas are most common for having phlebolytes, or you can say the calcium deposits in the hemangiomas. But you can rarely see calcium deposits, very less in cases of lobulated capillary hemangiomas, which are midline hemangiomas. So this is how you deal with a case of a nasal mass presenting to you with symptoms and signs like these. So you have to keep in mind it could be a vascular lesion, and the steps of surgery also you have to keep in mind. So I hope this video was really helpful for you guys. And if you have any doubts regarding the method of this patient's investigations or the procedure followed, you can just let me know. You can just give your views and comment in the section below. And you can reach out to my Facebook page or my Instagram page. Whatever doubts you have, I'll be surely happy to reply to all of your doubts. So till then, take care guys. Thank you so much.